have dementia with Lewy bodies. And so Parkinson's disease dementia is diagnosed in a patient who presents with motor symptoms first that could lead to just a Parkinson's disease diagnosis. This would be someone who maybe they have a tremor in their right hand that happens at rest. They're just sitting there maybe at the table and their hand is moving. They go to see the doctor. The doctor examines them, maybe finds a few other things going on and diagnoses Parkinson's disease. They may not have any cognitive problems at that point. But then over the years, and some people can develop this more quickly, some can, it might take 15 years. Eventually, many Parkinson's patients will develop cognitive impairment, and ultimately when that is severe enough, then we call it dementia. And so that's what Parkinson's disease dementia is. Dementia with Lewy bodies is a different disease within this category. So dementia with Lewy bodies presents with cognitive impairment either as the initial symptom or within 1 year of having any motor symptoms. So if there is cognitive impairment from the beginning of the disease course, then we call that dementia with Lewy bodies. There's a lot of, the biology is very overlapping. If when these patients, if they go through their course and at the end of life, if you're to look at their brain, they have really identical looking brain pathology. They have the same kind of alpha-synuclein deposits. There's something called Lewy bodies, which is hence the name for this category, Lewy body dementias. And so they both have those. They're both distributed throughout the brain at the very advanced stage. The clinical difference is the order of events. In Parkinson's disease dementia, they have Parkinson's disease really without cognitive impairment or without significant cognitive impairment initially, and only later gets problems with that. And then with dementia with Lewy bodies, the cognitive impairment is there from the beginning. So here are some more details about the core clinical features. And this is a description of the way that we formally diagnose dementia with Lewy bodies. I will say that all of these things happen in Parkinson's disease dementia as well. But the diagnostic criteria for dementia with Lewy bodies are organized this way, and I think it's helpful to go through them in detail to really understand what are these symptoms that cause problems in the Lewy body dementias. So these are the DLB or dementia with Lewy bodies diagnostic criteria. These core clinical features are worth spending some time looking at. Fluctuating cognition. So patients with DLB, typically, not all of them, but typically will report that they might have a period in the day, maybe for some hours, where they have great difficulty with thinking and memory. They may seem spaced out. Some people will sometimes describe how they feel that way. And then later in the day, they might be doing better, or vice versa. And there's this fluctuation that can occur. So that is what fluctuating cognition is, and that's one of these core features for dementia with Lewy bodies. A second core feature are visual hallucinations. So that's seeing something that's not really there. And these tend to be very stereotyped in DLB, dementia with Lewy bodies, and in Parkinson's disease dementia. They tend to be people or animals. It might be they look out in the yard and there are people out there doing something. I've had sort of positive descriptions. People there's a party out there and there are all these people out there. Or alternatively, it can be sometimes scary. I remember having a patient who told me they saw terrorists in his yard. Sometimes they are not really very intrusive or even amusing, and we don't always leap to treat them is one point there. If they're not causing a problem, we don't necessarily need to do anything with medicines, but sometimes they can be frightening, and that's where we do need to help. And there are medicines that can help with that, which I'll go through more later. The third core clinical feature of dementia with Lewy bodies is REM sleep behavior disorder. And this occurs in Parkinson's disease, either without cognitive impairment or with cognitive impairment, and it occurs in dementia with Lewy bodies. So this is a sleep disorder. Patients enact their dreams. They call out in their sleep. They might be having an intense dream, and sometimes it's a chase or a fight, and they end up punching in the air and accidentally punching their bed partner. And that is the kind of thing that can lead to a medical evaluation, even just for that. I follow a certain group of patients who they don't have dementia with Lewy bodies or Parkinson's or anything else. All they have is this REM sleep behavior disorder. And it by itself can bring someone to a doctor. But very often it's part of a broader syndrome, either as part of Parkinson's disease or dementia with Lewy bodies. And there's another condition as well that's less common, but it's worth recognizing. We're studying that condition actually as a very early or prodrome group for Parkinson's disease and dementia with Lewy bodies. And part of the idea there is to try to develop imaging tools to recognize the early brain pathology and hopefully have clinical trials to prevent those people from getting Parkinson's disease or from getting dementia with Lewy bodies in the future. So, but it is one of the symptoms on this list how we diagnose dementia with Lewy bodies. And finally, the last one is Parkinsonism. It's the symptoms that that bring someone into the doctor to get a diagnosis of Parkinson's disease, but they also occur in these patients who present with early cognitive impairment, and that helps us to diagnose dementia with Lewy bodies. And just to review, what does Parkinsonism mean? It is first of all, slowness of movement. We call that bradykinesia. But people whose movements have slowed down, often people just have general slowing down, the walking slower, the moving slower, the talking slower, everything. There can be a reduced amplitude of movement, and we pick this up oftentimes on the examination. If I have someone do finger taps, let me get in front of my camera. If I'm telling them to do big, tall taps, someone with moderate or severe Parkinsonism, it might get very small very quickly like that. So that's one of the features. The tremor I mentioned earlier tends to be a resting tremor. If they're resting their hand on their leg watching TV and the finger starts going, that's a typical rest tremor. So that's another feature of Parkinsonism. And then rigidity or just stiffness of the muscles, again, something we pick up when we examine them. That's another feature. So in order to diagnose probable dementia with Lewy bodies, we need two of the four core clinical features. There are sort of supportive tests, and most of the time this is a clinical diagnosis. But you can support your diagnosis with biomarkers. In particular, there's one that's gaining recognition that some patients may have heard of or maybe even had in the group, which is a Dat Scan. So a Dat Scan is this nuclear medicine scan where they have a radioligand. It's a drug that you inject, and then it's a tracer. It goes to the brain, and then it lets out tiny amounts of radiation to a detector, makes an image of the dopamine system. The dopamine system is what gets damaged in dementia with Lewy bodies. So that scan can say yay or nay, does the person have damage to their dopamine system? And that's helpful if you're trying to diagnose dementia with Lewy bodies. Some of these are, like this test is interesting, but it's not very available. MIBG SPECT it's actually an image of the heart, but it tends not to get reimbursed. So I really don't see people getting this. It's still kind of more in the research realm. And then you can get a sleep study to confirm your REM sleep behavior disorder. So I'm not going to dwell on this, a lot of text here, but it sort of restates how we operationalize the things I just showed you. Oh my gosh, I may have some construction in the background that started happening yesterday, so I apologize if that starts to happen. Oh no, no. Well, so the way that we use those criteria, we can kind of put it into the probable and the possible. The probable dementia with Lewy bodies patient has 2 or more of those core clinical features I was looking at, or 1 core clinical feature and 1 indicative biomarker. So if they have REM sleep behavior disorder and a positive DAT scan, for example, that would get you into that probable dementia with Lewy bodies category. Possible, it's not as certain that that's definitely what the diagnosis is, but it's still a suspicion, a concern. And so those patients can get there with 1 core clinical feature, like even if they just have the REM sleep behavior disorder, or they have one of the biomarkers, if they had a sleep study that showed REM sleep behavior disorder, for example. And this kind of, restates some of the same things. Again, I'm not going to dwell, but, recognizing, as opposed to Alzheimer's disease, one of the big differential diagnoses for dementia with Lewy bodies is Alzheimer's disease. And, the Alzheimer's disease patients probably are not going to have prominent, particularly not early in the course, visual hallucinations. They might get them later on in the disease, but that's usually at a much more advanced stage. And so if that's a prominent early feature, you're thinking dementia with Lewy bodies. The same with the REM sleep behavior disorder. That goes with these, this category, Parkinson's disease, dementia with Lewy bodies. They have the same kind of pathology that's different than what happens in Alzheimer's disease. So you don't typically see the REM sleep behavior disorder in Alzheimer's. You do typically see it in dementia with Lewy bodies. And then, of course, if someone has prominent Parkinsonism, the symptoms of Parkinson's disease, that also helps differentiate from Alzheimer's disease. So if someone gets a brain MRI and they have, strokes and a lot of blood vessel damage there, that would actually potentially explain some of what's going on. Not necessarily always. It's very common to have some blood vessel changes on the MRI. So someone can have dementia with Lewy bodies and have some vascular changes on their MRI, but we think twice if it's really severe, particularly if they have had strokes, because that can sort of mimic some of the things that you see. If the Parkinsonism only occurs very late, they've had cognitive impairment for 10 years, and then they get just a hint of Parkinsonism, we don't really go ahead to call that enough to diagnose dementia with Lewy bodies. That could theoretically happen in Alzheimer's. And so this is from the Lewy Body Dementia Association website. And they have done a lot of nice things on their website, a lot of patient information. And if you have a chance, I would encourage you to check it out. It's lbda.org, Lewy Body Dementia Association.org. And they have a lot of useful information. This is sort of a checklist. If someone is kind of self-checking themselves, or maybe they have Parkinson's disease, and they want to see if they're developing symptoms that would relate to PD dementia, this could be helpful as well. And so, some of the same things come out, like the hallucinations, acting out dreams during sleep. Those are things people don't necessarily know are part of the syndrome. They seem like something that could be unrelated because it's a different kind of symptom, but it is actually part of the Lewy body dementia syndrome. So now we're going to move on to treatment. And so I was mentioning earlier that the treatments for these conditions are based on the symptoms. So patients, they may have only some of these things. Very often, you don't see all 4 of those core clinical features. in the same patient. They may have only two, or even, they may truly have it and have only one, and maybe later something else happens and makes it clear that's what it's been all along. So you only treat the symptoms that are there and that are causing problems. If something's really mild, like if a person has a mild hallucination, once or twice a month, we're not going to give any medicine for that. In some of the milder forms of that, I could give examples. The patient's riding in the car and they look out the window and it looks like all the mailboxes on the side of the road are people. And then when they get up close, they recognize, oh, that's a mailbox. So that's kind of a milder, illusion. And they have insight. They know that that's not, really something disturbing happening. On the other hand, if someone has frightening hallucinations, there's people in their home that make them feel frightened, that's when we would use medicine. So treating hallucinations, or the other part of psychosis. Psychosis is also a category. It contains hallucinations and it contains delusions, which are false beliefs. Those symptoms should only be treated with very specific medicines in the Lewy body dementias. Psychosis in general happens in other diseases. Patients who have uncontrolled bipolar disorder or schizophrenia might get psychosis, and there's a wide range of medicines that get used in those groups. In dementia with Lewy bodies and Parkinson's disease dementia, it is very important to recognize that only a few medicines are safe. And this is a point that I try to belabor a little bit in this talk. It's that some of the medicines to treat hallucinations are actually very dangerous for patients with dementia with Lewy bodies or Parkinson's disease dementia. And these are the antipsychotic medicines they're dopamine blockers. They block dopamine. So in effect, they create the same kind of problem that Parkinson's disease or dementia with Lewy bodies do, a lack of dopamine. So they're blocking the action of dopamine. So some of the examples are things like Risperdal, Zyprexa, Geodon, Abilify. A lot of these medicines are used not only for psychosis, they can also be used for depression, like as an adjunct for depression. So they get used a lot. So it's helpful, like if someone has dementia with Lewy bodies or Parkinson's disease dementia, it's helpful to bring this up, if any of those symptoms are happening, are you sure that this is a safe medicine to use? Because remember, my spouse has dementia with Lewy bodies, and I know that there's some drugs that can cause problems when someone has hallucinations or delusions, these false beliefs. So I've unfortunately seen some sad cases where people who had, let's say, Parkinson's disease, they went to have a hospitalization for a procedure on their back, something unrelated, and then they might have gotten confused or agitated in the hospital, and then the people in the hospital, very often they like to treat agitation with Haldol, which can work for someone else, but in a patient with Parkinson's disease or PD dementia or dementia with Lewy bodies, it can be very harmful, and actually sometimes they have a worsening of, they might, if they had a little bit of cognitive impairment, it gets much worse, or they stay in this, their psychosis may not go away. So those are, sad cases, and that's why I spend a lot of time on that particular topic. It's sometimes helpful to get your neurologist to give you a note or a letter that you can bring with you if the patient has to go to the ER, to the hospital, just to explain that. So that's the one that I spend a lot of time on. Parkinsonism, for the patients with Parkinson's disease, they're familiar with this medicine, Carbidopa Levodopa, or Sinemet is the other name for it. That is helpful, in particular in Parkinson's disease. It can be helpful in dementia with Lewy bodies, but we have to be careful because its side effects are often exacerbating some of the symptoms of Parkinson's disease or Parkinson's disease dementia, including hallucinations. So if someone has very mild hallucinations and we go up on their Carbidopa Levodopa too much, they might get more severe hallucinations that really do cause a problem. Otherwise, many patients, at all stages of Parkinson's, at all stages of Parkinson's and in dementia with Lewy bodies, can develop depression and anxiety. This can be somewhat, dealing with the frustrations of the illness, but it's part of what the brain chemical changes of the diseases do. We can treat depression and anxiety with SSRIs. These are the serotonin boosting drugs. So serotonin is a brain chemical that is involved in mood, and having more serotonin promotes feelings of well-being. It promotes good quality sleep, restful sleep. Some patients get an improvement in their energy level when we boost their serotonin. And so it's a really useful drug in Parkinson's disease dementia, dementia with Lewy bodies, because those symptoms are really common. And we like to, when it's there, we like to identify it and treat it, because there are some things that we can treat pretty well, and this is one of them. There are certain things in the illnesses that we can't treat as well as we would like. So when we can find something that we can do a good job with, we're always interested to see if we can improve things. So definitely, if you notice you're developing, feeling sad more often than not, or that anxiety is a frequent issue that is it's not always just related to the situation, it's taking on a life of its own and maybe making your other symptoms worse, treating with an SSRI can be really useful. Cognition, we do have a medicine that helps with cognition. We don't have a miracle drug for thinking and memory. We wish that we did. But for this kind of symptom, we have cholinesterase inhibitors, and there's actually a range of them. They're all fairly similar in terms of how well they work. I picked donepezil because it tends to be the best tolerated, the fewest side effects. And so, that can improve alertness. Sometimes patients will get a little bit of benefit for their memory. It was really shown to slow down the decline in cognition in patients originally with Alzheimer's disease. However, it's also been tested in Parkinsonian disorders like Parkinson's disease and dementia with Lewy bodies. So, go ahead.
What happens if you stop donepezil cold turkey?
Sorry, there's a audio issue. Do you want to write it in the chat?
Yeah, if you could put it in chat, that'd be fantastic. I mean, I'll be happy to.
Yeah, if you could read it out, so that way I won't get out of my.
So,
It says chat disabled.
oh, okay. I don't know why. Okay, hold on a second. Okay, there you go.
What happens if you stop donepezil cold turkey? In general, we try to taper off of things. So the way that we start it is we give 5 milligrams at bedtime for a month and then go up to 10 milligrams. If many patients might stop at cold turkey and have no problem at all. And that actually does happen. If someone runs out of their medicine, it's not something where there's a dramatic withdrawal syndrome that is, commonly recognized. Like if someone's on a high dose of Xanax for a long time and they stop abruptly, they can have a seizure. So it's not like that. However, Any psychoactive or neurotransmitter modulating medicine, anything that does something significant in the brain, I think it's better to taper. So if someone was at 10 milligrams, I would have them go down to 5 milligrams for at least 3 nights before then stopping it. That's what I would recommend. A lot of people will get away with it, honestly, but a few people, it might, confusion could be a potential side effect. Thank you. And yeah, if anybody else has questions, either way, feel free to verbally or in the chat. So the next symptom I'll mention is orthostatic hypotension. So all that means is some patients, when they lie flat, their blood pressure gets higher. And then when they stand upright, particularly if they stand upright for some time, then their blood pressure may drop. And if that is a large drop, then sometimes that can make patients feel lightheaded or even pass out. And then the other thing is there's some more subtle symptoms that often get missed that can be caused by these blood pressure drops with standing. Terrible fatigue actually can be part of it. Now that's tricky because even if you don't have orthostatic hypotension, Parkinson's disease, dementia, and dementia with Lewy bodies can both cause fatigue. So it's not necessarily caused by orthostatic hypotension, but I always check for it because if you pick that up, there are things that you can do about it. There are medicines that you can give, and we can't really take away the problem of the drop. But if someone starts at 110 over 70 lying flat and they stand up and they go to 61 over nothing, and they're starting to pass out or about to pass out, that's the person who would benefit. If I first give them salt tablets or maybe even give them a medicine that raises blood pressure, there's one called Florinef that we usually start with, that shifts that range up. So if they start at 139 over 80, and then they drop to 98 over 60, they're probably not going to have any symptoms, and it's a much better place to sit with your blood pressure. So that's again a treatable issue, but the tip-off symptoms would be lightheadedness on standing, or if patient has terrible fatigue. I've even seen patients who they have an exacerbated depression when their orthostatic hypertension is not well controlled. So it can have mood effects even. It's worth thinking of. Just to tell you, the way that I test for it is very easy, and you can do it yourself. Basically, if you own your own blood pressure cuff, like an automatic blood pressure cuff that you get at Walgreens, CVS, any pharmacy, or Amazon these days, then you could do this yourself. You lie flat. You have to lie flat for at least 2 minutes. Take the blood pressure and the heart rate with the automatic cuff. Have a little diary. And you have your date, and then one column is lying flat and the other column is standing up, and so you record your lying flat 2 minutes blood pressure and heart rate, and then you go from lying to standing. You wait another 2 minutes, and again use your automatic cuff to take blood pressure and heart rate and record it in the standing column. And then I usually, when I'm having a patient do this, I have them do it twice a day, like morning and evening, for a week, because it can be intermittent. It's not necessarily always there. And so that way you'll pick it up, and you'll also know how severe is it if it's there. If there's a big drop, particularly the top number, the systolic number, if that, lying flat, if someone's 160 and then it goes down to 100 standing up, that's a pretty big systolic drop. And you'd want to know about that, even if you're not having problems. If I go up on Carbidopa Levodopa because someone's, walking gets worse or their tremor gets worse, that can also make orthostatic hypotension worse. So it's a good thing to be aware of and to make your doctor aware of if it is there. As you can see, this is also pretty complicated because a lot of the symptoms of Parkinson's disease, of dementia with Lewy bodies are exacerbated by some of the medicines. So that is a recurring theme in the management of these conditions. So it's a pitfall. And we as physicians have to watch out for it. Finally, urinary urgency, also very common. Urinary urgency is a common symptom even if there's no Parkinson's disease or dementia with Lewy bodies. And so, in men, the prostate is often to blame or partially to blame. In women, there can be other kinds of anatomic changes in the pelvis that can contribute to this. And so, if someone is having urinary urgency, it's not necessarily all just Parkinson's or dementia with Lewy bodies, but it can be. So very often, one of the things I do is I'll send them to the urologist to figure out what's what, because there's different medicines for the different kinds of urinary problems. But the problem that's caused by Parkinson's disease or dementia with Lewy bodies for urinary symptoms is, we can refer to it as an overactive bladder or neurogenic bladder. If the bladder is overactive, we can give a medicine to keep it from being prone to kind of spasm and make you have to run to get to the bathroom. There's a long list of medicines for urinary urgency. Not too many of them are really what I would recommend in this situation, because one of the side effects for many of them is confusion, which of course is a bad combination for these conditions. So the least bad in the category are one called Mirabegron, which the brand name for that is Myrbetriq. And then there's trospium, and the brand name is Sanctura. Mirabegron is good, it works well. The side effect profile is relatively benign compared to the others. It tends to be more expensive, so sometimes that's an issue. The trospium is a little bit older, but also a very reasonable choice in the situation. And I believe it is generic. That seems to be easier to get without a big cost issue. There are other ways of treating symptoms besides pills. And so it's very much worth emphasizing every appointment that I have with a patient with any kind of neurological disorder, at least the ones that I see, one of the speeches that I give is about exercise and how valuable exercise is. And I know I'm preaching to the choir here at Aloha to Aging, where you've emphasized this, and it's a great thing that you do that. Exercise has benefits for cognition, slowing down memory decline. It also has physical benefits, preserving mobility, preventing people from progressing to disability. And so it really is effective in those areas in ways that no other existing treatment is. So, there are a few, considerations as we think about exercise. So particularly if someone has, PD dementia or dementia with Lewy bodies, those are more advanced stages. So we do need to think about safety when we are talking about exercise. So particularly if someone is very unsteady and prone to fall, that's when often I'll have them see a physical therapist to help evaluate them and create a regimen that's safe for them to do. We want to have them, do things to get their heart rate up. If people like to do, things like, light weights, that's okay too, but at least half the workout should be aimed at getting the heart rate up. And then with the safety issue, sometimes I'll involve the physical therapist to try and come up with a good plan. For patients who do not have as much, balance problems, they're not falling, there's some great physical therapies that are really targeted towards Parkinson's disease and Parkinsonism. And the studies are really about just Parkinson's disease, but I, recommend it for people who can tolerate it, who have some kind of similar Parkinsonian disorder. There are the big and loud therapies. And so there are certified therapists who can do these therapies, and they are targeted towards the motor symptoms that happen in Parkinsonism. So the underlying principle is to sort of use your conscious effort to overcome some of the the changes that Parkinson's disease and dementia with Lewy bodies cause. In general, these symptoms, Parkinsonism, they consist of kind of a loss of some of the automatic motor activities. So normally we don't have to think about walking and taking a good stride length. Normally I don't have to think about, what's the amplitude of my movement if I go to reach for my mouse. But in Parkinson's, the amplitude or the size of the movement is decreased. So you're kind of expecting to take normal stride length, but it gets short. And so people get these short shuffling steps. And so a treatment for that is to don't leave it up to the automatic motor program, because it's not working as well as it used to. Consciously make an effort to take a very large step, and that will translate into a normal size step. And the same, you might need to exaggerate your movement to feel like you're really reaching high, and that'll just be kind of a normal reach. And so it's the therapy is really targeting that concept where they have you do a lot of exaggerated amplitude movements, make big movements, hence the name. And that is an effective therapy, and it has a lasting benefit. Even they do an intensive 5-week session, and patients, when they looked at them 6 months later, they still had benefit. And I always tell my patients, do your 5-week intensive session, but learn the exercises. They have a DVD, or you can do it online to get the videos yourself, and then to continue doing them. And then the speech therapy equivalent is loud. People get quiet voice, hypophonia in Parkinson's, and in Parkinsonism and dementia with Lewy bodies. So for the quiet voice, it's the same principle. The exercise to project your voice and to speak, feel like you're shouting, but it comes out at the right volume. So a similar concept. Other things, again, this is more, for people who are not, really prone to falls, but boxing classes, you'll encounter these very frequently now, which is good. A lot of patients get really into that, and I think it's great. Not everybody is, focused on doing boxing as their main exercise, but for some people, it's just it really resonates with them. So that's a great option. And the number one exercise that I recommend is walking. If someone is prone to fall, they might need to use their walker. They might need to have a family member or a home health aide or someone with them. But just using what you've got is really important, and it's really beneficial. And like I say, it helps both cognition and motor symptoms. This slide allows me to belabor the same point that I made before, which is well worth doing. Antipsychotic medicines, other than the approved ones. So these are the good ones. The good ones are quetiapine, pimavanserin, which you may recognize from the brand name Nuplazid. Those are the commercials that everyone is seeing that describe hallucinations in Parkinson's disease and Parkinson's disease dementia. But the generic name for that drug is pimavanserin, Nuplazid. That's pretty new. And then there's another, this is an old drug, Clozapine, which is also effective, for psychotic symptoms, hallucinations, delusions, in the Lewy body dementias. Clozapine is hard to use because you have to do a lot of close blood monitoring. It has a rare but fatal side effect, potentially fatal side effect of suppressing the bone marrow. It's very rare, but it's very severe. So that's why it requires close monitoring. We don't end up using it very much for that reason. So quetiapine remains the most common. And then I would say increasingly, people are starting to get pimavanserin or Nuplazid. Any of the other antipsychotic medicines, dopamine blocking medicines, and they're long names. I don't expect you to remember all of these things, but just so you've heard, the most common culprit is Haldol. And so if you have Parkinson's disease or dementia with Lewy bodies or Parkinson's disease dementia, or your family member does, and the doctor says that we can give them some Haldol, say, no, 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 my doctor said that we're not allowed to do that. Please, speak with the neurologist. They should, if they have a neurology consultant, like if it's the medicine doctor on the primary team in the hospital, ask them to ask the neurology consultant, and they'll know that's not allowed. That one drug, if you remember, no Haldol, that will be worth remembering. There's actually a list of them that can cause the same problems: Risperdal, Abilify, Zyprexa, Geodon. But bottom line is be wary of these medicines that they get used for hallucinations or agitation in the hospital, and make sure that there's a neurologist involved to help prevent that problem.
Dan, we do have a question of what's wrong with Haldol. What is
I will tell you.
Okay.
So Haldol is a dopamine blocker. So dopamine is the chemical that is reduced in Parkinson's disease and Parkinson's disease dementia with Lewy bodies. And so if you give a drug that, in addition to the lack of supply of dopamine, it also blocks the action of whatever remaining dopamine there is, the patient's going to get very severe Parkinsonism. They can maybe just really can't move, frozen. And it's not just motor, it's also cognitive. They can become very withdrawn, and the details of why this has such a profound effect cognitively is not thoroughly understood, other than to say that dopaminergic projections and dopaminergic activities in the brain are certainly involved in cognition. Sometimes people just never recover after they receive it, particularly if it's a high dose. Which that often is part of the approach when it's used for agitation in the hospital. So I've seen that before. It's very sad. So you just want Haldol to be avoided. Now it can be tricky because, like I say, there's a lot of other ones that can do it. I mean, they're used in similar situations. The other pitfall there is, even if it's a medicine not for hallucinations or agitation or delusions, some of the anti-nausea medicines are dopamine blockers also, and have the same kind of activity as Haldol. And not all of them, but some of them. So the ones that are bad are, so Reglan is very commonly used. The generic name is metoclopramide. And then Compazine is another one. So nausea medicines, pretty much most of them have this problem except for one, and it's called Zofran. Zofran is fine. And so if they're giving Zofran, not a problem. If they're giving any other anti-nausea drug, again, a time to raise the question, hey, do you remember that they have Parkinson's? Do they remember that they have dementia with Lewy bodies? A different issue, this would not be for hallucinations or agitation or delusions. This would be, the patient who is feeling very anxious. Many times they will receive this drug category called benzodiazepines. Now, the familiar names are things like Valium and Xanax. May have heard of Ativan. And there's a long list of these too. But they get used for anxiety. They get used for sleep sometimes, but they can cause confusion, and there's an increased rate of falls. So in general, we avoid those. Now, there's an exception to this as well. All of this is complicated, and I realize I'm going through a lot of details because a lot of times people are interested in, how is this really working? But I think the take-home message is, there are medication pitfalls. So, make sure that your doctors know the patient has, Parkinson's disease or dementia with Lewy bodies or Parkinson's disease dementia, and that they're thinking about that when they pick medicines. The exception for this is we do use a benzodiazepine called clonazepam pretty often. We use that only in small doses at bedtime. And that treats some of the symptoms. For example, that REM sleep behavior disorder I was talking about, where the patient might act out their dream and accidentally punch their spouse or fall out of bed. Sometimes that's a real problem. And so that one of the best medicines for that is clonazepam. So, you know, some of this is just kind of, you know, going back through, but in a different way. You know, there can be a lot of confusion from some of these symptoms, particularly the psychosis is something that people aren't always expecting. So, you know, someone who, you know, suddenly starts to believe that their spouse is an imposter, for example. That might sound very unusual, but in fact, it's this almost stereotype thing that happens very often in Parkinson's disease dementia and in dementia with Lewy bodies. So recognizing that, you know, strange kind of beliefs and strange behaviors like that are part of the disease and actually treatable. You know, so people might not know that they might think that they're having a problem in their marriage, but really it's just the disease, and it's a good thing to bring up with the doctor. Same with REM sleep behavior disorder. People, you know, it used to be people would always think this was a psychiatric problem, when really it's a neurological symptom. So a lot of people have it and don't go to the doctor. So, you know, just know that it is a neurological symptom that goes with these Lewy body dementias, and it's treatable. Things that can precipitate a crisis. Sometimes the, you know, delusions, hallucinations, agitation can reach a really, you know, exacerbated place, and it can be really difficult. And there are times when people, you know, they need to, they need more treatment. And I would like to be able to say that, you know, just going to the ER is always a great solution. It isn't always a great solution. However, if there's, you know, if there's a danger to the patient, a danger to a caregiver, yes, that's correct. And then sometimes even a psychiatric admission, you know, that's the way that we would like for that to go if they end up in the ER, is to then the ER, probably very often the ER, it doesn't have an inpatient psych ward at that hospital. Sometimes they do, but they can figure out how to get the person to the right treatment. And in, you know, psychiatric hospitals, you know, they should be very aware of psychosis as a manifestation of these diseases. It's, you know, not every psychiatrist is really well versed with this, so that's worth saying too. But I'm familiar with some around town. There's a Dr. Pack who he's, I believe, at Ridgeview, who I've had patients go to before. Falls, you know, everything we can do to prevent falls is very useful, but we can't prevent every fall. And certainly, you know, that is sometimes the thing that, you know, accelerates things. So when people are starting to take falls, I usually advise, you know, have your plan made for if the home environment isn't safe, what are you going to do? Like, you know, sometimes it's getting someone in the home, you know, more hours or even 24 hours, which gets very expensive, versus like assisted living or even sometimes skilled nursing. So thinking through all of that before the crisis forces the issue is really important. And so I try to bring that up early when people are taking falls. There's a lot of frustration, understandable frustration, with the lack of having enough treatments to do enough for these things. We have treatments that are helpful, and you know, we're doing things that are useful. We wish we could do more. So we need better neuroprotective treatments. And so we do have at Emory the Lewy Body Dementia Association Research Center of Excellence. And that's something that I'm the director of that. And one of the things that we do is research. And so my research focuses on MRI studies of the dementia with Lewy bodies and Parkinson's dementia patients. And those are really targeting biomarker development, trying to make tools that will make the clinical trials more successful. From time to time, opportunities come up to do clinical trials. And so that is something that we're interested in. We don't have one right now that's recruiting, but I believe that there is going to be a phase 3 trial sometime probably in the next year. They haven't really announced when it'll be, but there's a drug that came through phase 2, and we anticipate they will probably do a phase 3. So when those opportunities arise, we try to get involved and connect patients with those trials or enroll them at our site. So that's kind of where that is. We need these neuroprotective treatments, and there are efforts underway, and we just hope that we get one successful as soon as possible. So I do, like I said, we have research opportunities. So you can, if anyone is interested in research, could certainly, I would be very interested in having you participate. So my research coordinator is Kelsey Tucker. And maybe, I guess, Dawn, if it's okay, if someone is interested, do you mind forwarding their info?
Nope, that would be great.
And would love to connect you with a research opportunity. I think we're about out of time, but these were kind of going through examples of symptoms that happen, and I pretty much interspersed that as we went. And I just want to acknowledge, all of the research that we do is supported by either the NIH or foundations or philanthropy, and I always acknowledge them. And then everything that we do for research is, collaborative and involves a team of people. So I always acknowledge the other people I work with as well. And that's what I have.
Well, Dr. Huddleston, that was fantastic. I think, you made some really valid points. When we do the Parkinson support group, we do talk about, obviously, the exercise. Several of the people have done the big and the loud, and which has been fantastic, as well as the boxing. And we will definitely share this with the group, and whatever, you need us to do, we'll be supportive. I did have a question, and if you just have a couple minutes, if anybody else has a question, just kind of
Sure.
speak up. But one of the things they had a little few years ago was the Pulse, the physician ordered life sustaining treatment form. Are you all still using that? Are you familiar with that for emergencies only? I know we used to hand it out, and we said, listen, keep this in your car, keep this, in your purse, so that, God forbid, especially if you do have a condition that, because we had too many people that were on the Haldol or went on something because they weren't familiar with the actual disease that maybe the person had, or they weren't able to speak for themselves. So any other suggestion?
So that sounds interesting. I mean, I don't have a specific form. So in my own practice, I create a letter and I give it to my patient. But that sounds like a nicely sort of, distributable format. So I think that sounds like a good idea. If I understand, it's basically, it's a list of here's what not to do that they would bring to the hospital.
Yeah, it's a whole form that wherever they go, and actually it was supposed to be signed by a doctor, medical order, and actually in your file. And several of the hospitals were actually had it in a red folder, so you had it. So it was actually not only where you go primarily, but then you made extra copies that you'd have it if you're visiting family. The whole.
That's a great idea. If you have a link to that form or something, do you mind emailing me?
Yep, absolutely.
And yeah, I would. I mean, based on that description, yeah, I would recommend doing that. That's the exact issue. I mean, I know that's why you're bringing it up. That's the exact issue that I was talking about. It's really important.
Well, Dove, I know you came in a little bit late. Did you have anything, or Sandra, do y'all have anything you'd like to ask? Mute. Okay, so
Yeah, I had to unmute myself. Al's gone, and he's my technical person. I know it. Okay, so today, your initial graph, we were talking about Lewy body dementias, and they progressed to two others, the Parkinson disease dementia and the dementia with Lewy bodies.
Mm-hmm.
So Parkinson's disease in and of itself does not necessarily have Lewy bodies. Is that what you're saying?
No, it's not that Lewy body dementia progresses to these things. It's sort of it's the classification system. So this is a big group, the umbrella term, Lewy body dementias, and then subtypes of Lewy body dementia are Parkinson's disease dementia and dementia with Lewy bodies. So these are, the entire category, and both subtypes have Lewy bodies. And even Parkinson's disease without dementia also has Lewy bodies.
Okay, that's what I wondered. Parkinson's without dementia has Lewy bodies. I had read that someplace, but then I was questioned on it and I didn't know more
Sure.
specifically.
Uh,
Okay, so Parkinson's disease, I've had it 2 years. I've got a resting tremor and I had the positive DAT scan. So, but I feel like with the Carbidopa Levodopa, I'm at a point where actually I can smell a little bit better now.
mhm.
I can smell my compost in my kitchen.
Uh-huh. That's
But
good.
and my tremor isn't as bad as it was when I first started on the med. So but I exercise. I walk 4 or 5 times a week, and I do some stretches, and so I try to do stuff like that. So does it progress differently with different people? I've heard people say they've got it for 10 years, 8 years, 14 years. Well, I just want to be aware of, sometimes I don't know if I'm just getting old, and what I feel is I'm just getting old, or is it the dementia? It took me a long time to recover from, I think it took me a long time to recover from hip surgery. Is that just the hip surgery? Or is it part of the role that Parkinson's play in the recovery from hip surgery?
So a couple questions there. So one is just about the how rapidly things progress, how long, what's the total duration of Parkinson's disease course. So it's variable, and if someone has their first symptom of Parkinson's disease when they're 77, then they may have a bit faster course than someone who has their first symptom when they're 57. On the other hand, it's probably not very likely to be the thing that takes their life, because they're 77 and their other health issues sometimes come up before they get all the way through all the stages of Parkinson's. So depends on the age of onset. It is also just variable from one individual to the next, and all the reasons for that are not deeply understood, and we suspect there could be genetic factors that may play a role, and of course lifestyle factors, how much they're exercising. So I try to focus on the latter. There is the opportunity to change one's own trajectory with Parkinson's, and it is with exercise. And I can say kind of anecdotally, I've had patients, I had a patient I can remember who has had course, he had it for over 30 years and was still walking and mobile. And he had been a runner most of that time. He had gotten back to just walking by the time he was at 30 years, but doing remarkably well, and I attributed a lot of that to his exercise. So focus on those parts where you can control the trajectory, but yeah, it's variable. There are people who have a more aggressive course, and particularly if they get to the dementia part quickly, that portends a more aggressive course. So it does vary. As far as your hip surgery, recovery from any surgery or illness, if someone gets pneumonia and they end up in the hospital, or heaven forbid COVID, it takes longer to recover from things when you have Parkinson's. If you're off your feet because of some illness or surgery or injury, regaining mobility is harder. Some of it is just, it's harder to do physical therapy, and it was hard to initiate walking to begin with because of Parkinson's, and then you have an injury on top of it. So things do kind of, pile on a bit when there's another medical issue. Avoiding falls and being extra careful with, masking and avoiding COVID. I mean, you can't control everything, we have to admit that too, but it can be more difficult when you have Parkinson's or dementia with Lewy bodies to recover from illnesses and surgeries.
Well,
Did I cover everything?
yeah,
Yes, fine, thank you.
I so appreciate you taking the time. You did a fantastic job. That was very thorough, and we got all your points.
Well, I appreciate the opportunity to speak, and hope it was helpful.
It was absolutely great. And we did record it, and we will put it up on our YouTube channel. So if you're good with that.
I'm fine with that. Do you mind sending me like an email with a link or something? Because I have a website, and I kind of put some of these things on there too. So
absolutely, will do.
Great.
Well, thank you so much. Great to see you. Stay healthy.
Likewise, great to see everyone. Stay healthy, and hopefully all this COVID stuff will be over soon.
Amen to that. Okay.
What? Oh,
Oh, yeah.
just,
Yes, Sandra, did you want to ask him another question?
I just wondered if for a person getting the COVID vaccine, I know having the disease is worse than not having it, but does it take longer for it to kick in? Will we feel the side effects more? Just wondering.
So, I don't think anybody has that answer though, because it's all new. I mean, I think that's the key thing. It's interesting because he keeps saying exercise, which of course we always say too, it's that and hydration. I'm telling you, with all the different medications that we're taking, and especially if you are walking, all that, hydration cannot be, emphasized enough. And, it doesn't mean 10 gallons of water. It also means oranges, grapes, tomatoes, celery, all those things have water in it, for hydration. So I think that's the other piece that needs to go along with that, especially when it comes to the medications. And, I do appreciate what he said. Now, do y'all remember when I did the pulse? Remember when I put that out, the physician ordered life sustaining? Well, isn't that interesting? Because it was so funny. Wellstar, was doing a whole thing, and then they merged with Piedmont, but they were doing it's called it's a pulsed. So actually, let me just see if I can pull it up real quick here and attach it if possible. I don't know if I can do this, but pulsed form. Yep. And it was for Georgia, and it's a PDF. Let's see. And yeah, they were all Georgia. Yeah. Especially, we were having a lot of people that was being, well, the key thing, okay, let me see. People were being readmitted for the same issue, and download the Georgia here. Okay, let me see. And so the hospitals had to figure out something because, of course, they were going to be penalized for that. So let me download it and let me see if I can post form. So that was back in, this initial one was back in 2016. And the key thing is we said, already exists. Do you want to replace it? Yeah, replace it. Use it anyway, carry it with you. We were saying have as many copies as you can. And also, like I was saying, if you're visiting somebody, let me see if I can get it up there. If you're visiting somebody, make sure you have it with you. Keep it in your car. Let me see if I can. Yeah, I can upload a file here. So let me. Dove, I know you're with us here.
No, I'm here. I finally took my mute off.
Yeah. Google Drive, I think. I see.
Let you know I got back in here, so I'll be here for a little bit.
I know. Look at you, just like ram. That's pretty amazing.
Yeah, Sandra, are you aware I'm here?
Yeah, I see you.
Okay.
Did you have your test already?
They're making me drink gallons of water before I go in for the CT.
Oh,
See, there we go. Everybody needs to be drinking gallons of water.
there I am.
Yay. Okay, let me see if I can upload. See, it won't let me upload it from there. Okay, I'm gonna I'll email it to all of you.
Okay.
That's good.
Yeah, so they should have it. But yeah, it was a big thing in 2016. And let me, I could do a screen share. Let me pull it up just so you can all see it.
I was just diagnosed in 2018, so that would have been before.
And
our time.
yeah, okay. Let me do a share screen here, and that way you can all see it. I lose track of time. Even me lose track of time. Okay. Do you see it?
There it is.
Okay. So what it's supposed
I think
to,
I have this.
yeah, so it's a physician ordered. So basically you go through it with your doctor to say, hey, if it's code, if you hospitalized, that's the key thing, what you want. Okay. So it's not only end of life kind of thing, but here it's, look, antibiotics, and then additional orders, okay? Because we all know there's some issues with that as well. And then down here, okay, the doctor signs it, but there's other guiding for completing this form. You can add as much to that as you want, and updating it and everything, but it was something that each of the hospitals made sure that it was kept, so it was in your file, but it was in a bright, big red, so they knew to pull it. So case emergency, red. And then again, you add additional orders. So you add, they'd add something else to it. But the key thing is that it's signed by a doctor. So it's you and your doctor. So it is an order. So in other words, if you were in the hospital, they have to go by that. So that's something that was definitely one of those things that was very helpful for everyone, especially if, you are by yourself. I mean, if you're going to the grocery store and you're not with a family member and something happens or whatever it might be, or like I said, you're visiting or any of those things. But even comfort measures. So use medication by any route, positioning, wound care, other measures, so all the different things that you have to think about. And isn't he great? Have you ever met him before?
I have. I was in one of his studies.
Yeah. Okay. Well, he's very sweet. I mean, and he's, got a big,
Very, very caring.
yeah, very sweet. And he's got a big heart. And he was actually on our board for a little while. And, God bless, he's so busy because he lives right down the street from the center. But, he's so full with Emory, and he's got 2 little ones. He's like, Dawn, he goes, I'll promote y'all, but I'm sorry. I'm not going to be able to give us the time that I'd like to give. And I said, okay. But yeah, he's very, very knowledgeable too. He wants to find the answer for you too. I think that's the other thing. So, oh, he's all masked up. Yeah, we don't want to catch anything. So make sure you keep that mask on now.
Yeah, well, I had to drink all that water. Now I got my mask back on. I finished with that.
Oh, so you're actually at the office. Look at you.
Yeah,
You are Mr. Techie. Oh my God. Oh, you're right.
I'm sitting in the waiting room here at Wellstar.
Yeah. Oh my God. Look at you go. Oh my God. That's so funny. I love it. Technology. Uh-huh.
Somehow I'm off a week. I kept thinking this is the second week in January. It's the third. Was yesterday's doTERRA conference recorded?
Yeah, but
we have it again.
No, so we're going to do it again. That's what I emailed you. So just so you all know, we are no longer going to be at Mount Bethel Community Center. So they have pulled the rug, shall we say. So I am moving, and oh my gosh, I have different volunteers in different parts of the building helping me sort, pack, and so then I ran back home for this. So we are definitely, we've always been mobile, just since you guys have only been with us a couple of years. We take our stuff all over the place. So I'm not worried. We're going to find another space, we'll say, to meet. So that will never be an issue. Oh my gosh, we used to be at Catholic Church of St. Anne's. They would welcome us back there as well. Even Mount Bethel said, well, we'll have a space for you. I'm like, no, thank you. I'm like, I'm going to cut my ties and move forward. So, yeah. And there's several doctor's offices. I mean, so I'm totally fine. As far as, address right now, it's just mine, for mailing and stuff. But, just so you know, I'm going to put out a thing that says, hey, we're 100% mobile until we find a space. So I'm actually going to talk to Wellstar, because, they've got all these, parks now, East Cop Arc. I mean,
Yeah, they got community rooms all over the system.
that's
They have one here, but right now they're using it for giving the COVID shot.
right. So I think there'll be plenty of opportunity for us to potentially meet at another location without we will without an issue. So I'm not worried about it. And of course, I'll make sure that all the wonderful places have the chairs with arms and all that kind of good stuff. So yeah, we'll be fine. And it was so funny, Dove, because you weren't on here, but I said, oh yeah, I said, and Dove Johnson, I said, I'm not sure if you remember her, but I think she did something with you. I actually said that when we first got on, but she's actually doing, I think, PT right now on Tuesdays and Thursdays. So she probably won't be on here.
Well, it's just been a little crazy here of late.
Well, good,
But
crazy, because you're busy. So
Yes, and the PT is helping tremendously. It's going over to Executive Park to get it, so I'm getting the right kind.
good. That's awesome.
It really is. I'm grateful for it. And hearing him say again about how helpful exercise is, I'm so glad I'm able to do that again. And I've managed to get back to the senior center in Roswell to ride their bicycle. Found out what time of day there's nobody much there. So I'm on the right track.
Excellent. Well,
Yeah.
that's key. Yeah.
It is.
So, Sandra, you're doing, the only thing I'd say is, in addition to the walking, is to add some strength training, because that's muscle.
Okay.
I mean, you can grow muscle, add muscle, build muscle at any age. So I think, that's the key thing. And we actually for January moved our Tuesday exercise to 10 a.m. and we are doing some weights and bands and stuff. And, you're welcome to join us if you want to do that. It's every Tuesday at 10. So we might have to move one of those, but normally everybody that shows up, we're just going to tell them we've got where we're doing it right now.
So
we
is that a Zoom? Is that a Zoom thing?
Yeah. And it's on the newsletter.
Okay.
So I hate to cut you guys short, but I actually have a 3:30. Shoot me now.
I need to go too.
Oh my God.
Thank you, Dawn.
Oh, thank you. Thank you all. It's great to see you. And hopefully we'll see you soon. Okay.
Yes, take care.
Bye. You too.